Yes, so I think it was not nice to give some arthroscopic surgeon to talk on open release. So there are two disclosures. One is no financial disclosure, and other is I have already lost the battle. So in the end, in voting, I will also go for arthroscopic. So, but obviously there are some reasons, I mean, why we still may consider open. So that's what I was trying to discuss, we'll try to discuss. And even go for maybe last 2 to 3 decades, you will hardly find any literature to support now open release as a primary surgery. So again, remember, as a primary surgery. So arthrofibrosis is a common complication that can lead to loss of knee range of motion, loss of strength, pain, stiffness, inability to return to previous level of activity. And we usually encounter a surgeon in 2 scenarios: post ACL or post ligament reconstruction, and then post total knee arthroplasty. The rates are almost same. So post ACL almost 5%, and when you combine more ligament, it's up to 13%. And similarly for revision and total knee arthroplasty, around 4 to 5%. So definitions, I have used the word definitions, not the definition, because still we don't have consensus what is the actual definition. When you talk about cellular level, it is the deposition of fibrous tissue, extracellular matrix composed of collagen, and somehow many factors might be involved, including genetics as well. The suprapatellar pouch, anti-interval, intercondylar notch, medial lateral gutters, posterior capsule, infrapatellar fat pad, these all areas may show some extra deposition of extracellular matrix, leading to contractures and shortening of the tissues. So when you are planning for any surgical intervention, you need to consider these things in mind, where you are trying to, which area you are trying to address more. There are several definitions clinically which we are interested that in the past it was defined as symptomatic loss of knee extension or flexion compared to opposite normal knee, or you can say a patient is said to have arthrofibrosis when the limitation in knee range of motion becomes permanent despite your conservative management. Then you can label it patient has arthrofibrosis. This classification was given by Shelbourne in his classic paper in 1999, maybe more than 2 decades ago. And this was also based mainly on his experience with the post-ACL arthrofibrosis management, where the type 1 was less than 10 degrees of flexion or extension loss with normal flexion, and type 4 was more than 10 degrees of extension loss. So this was the first time the extension loss was also considered as significant in terms of knee stiffness. So now international panel consensus definition is there, where postoperative arthrofibrosis knee defined as limited range of motion extension or flexion measured by active flexion extension, which is not caused by infection or other specific causes, and they have classified into mild, moderate, severe arthrofibrosis. So this is important because you have to decide where you will want to go, arthroscopic or open, depending on which category you are dealing with, it is severe or it is mild. So the presence of pain is also again important. There are risk factors: younger than 18 years of age, reported in literature, component meniscal or control procedures, female sex, early surgery, as it was already discussed, and then quadriceps operated tendon allograft may give to more arthrofibrosis. So obviously it is frustrating, disappointing for both surgeons and patients. Now what to do? We have different options: physiotherapy, manipulation or anesthesia, arthroscopic, and then open release. And obviously, as I said earlier, you can hardly find literature to support as a primary procedure for open surgeries when you're dealing with arthrofibrosis. So this may give you some hint what are the components to consider. There are certain extracellular and there are certain extraarticular, certain intraarticular. So intraarticular adhesion, excessive fibroblast formation, these are extraarticular, and then intraarticular. Then extraarticular is usually muscle related: quadriceps tendon, patellar tendon retraction, muscle scar, adhesion to skin, and these things. So, so I will be skipping. So this paper is again more than 2 decades old. They are recommending open surgery after you have failed arthroscopic. So when you have a role of open surgery, again, this slide is showing pros and cons of arthroscopy, but the cons will guide you when you will consider the open. So arthroscopic cannot address the extraarticular causes of stiffness. Neurovascular tissues are at risk. Posterior knee surgery might be easy with arthroscopic, but there are more neurovascular chance of neurovascular damage. May not be so effective in long-standing cases, in old cases, and may not be able to correct severe deformity when you are going arthroscopic. And obviously, you need significant expertise to do arthroscopic release when you are performing these things. So a prerequisite is adequate visualization. So if you're not able to visualize, you may not be able to release. What are the advantages? Ease of debridement and the ability to exercise periarticular and extraarticular lesions, evaluation of soft graft position, function, and impingement that may be better with open. The extensor mechanism can be mobilized more thoroughly with the open surgery. The posterior capsule is more easily assessed and can be more thoroughly released. The femoral or tibial capsule or both can be released to gain additional extension. So now when you are talking about this extensive surgery, the more better hemostasis you can achieve with open technique as compared to closed technique. Obviously, more better hemostasis, more less post-op effusion, and less chances of extension leg after surgery. So prevention is better than cure. Again, anatomy reconstruction, adequate fixation to allow early range of motion, and then adequate rehab. So thank you. So my vote again will go for arthroscopic for primary case.